Good morning, Dr. Connor here. Today's topic is one that I hear a lot about and I have lots of questions about from both parents and medical providers alike. And it's really about young and older children and intoeing. Intoeing is something that's pretty common in the population, especially in young kids who are in the early phases of walking and the early phases of balance and coordination. And then as they're going through toddler phases and into adolescence, we definitely will see some kids who will persist in their intoeing. Additionally, some parents also have anxiety because they themselves or their partner may have experienced intoeing and may feel that they have had some problems related to that. And so um, they want to get this addressed at an early age and they want to get it dealt with so that it won't cause a problem. Lots of parents will feel that their child is having problems with walking or they're delaying walking or there's some balance issues or lots of different things. And so we field a lot of these questions and we'll do these assessments. So as an orthopedic surgeon, when I think about intoeing, especially in a younger child, I'm looking at three different things. And it's usually assessed by age, but usually when we're talking about the legs, either the problem's going to be in the foot, it's going to be in the leg itself, or the tibia, the shin, or it's going to be in the femur, which is the thigh. And each one of those has different age brackets that they tend to fall into. And so for those children who are firstborn, so those who are less than a year old, very young, and may be born with turning in, often it's at the foot. And the technical term for that is called metatarsus adductus. Really what that is that the foot is positioned against the uterus, and because it's positioned against the uterus, it's actually turned in and it's pushed in, so that once the child is actually born, the foot still remains in that position that it's turned in. So it's often something that you can see right at birth. You can see the foot that's turned inwards like that. Often it's flexible, meaning that if you grab the foot and you just wiggle it and you try to straighten it out, it will come back to just being looking like a normal foot, but then you let it go and it will drift. And it doesn't hurt the child, doesn't hurt the baby at all. And that's sort of characterized by the toes making a banana shape. So the foot making a banana shape and the toes deviating in. And so this is a condition that really spontaneously corrects or self-corrects itself, often within the first year. If it's significant, meaning that there's quite a bit of a turn, or it's a little bit rigid, meaning it doesn't necessarily want to go back to being straight, you can do some other things like casting or different types of bracing. It's usually not necessary, and usually I recommend that parents will take a picture of the foot. And so just getting your camera phone, looking at it from the top down, taking a picture of the foot, and looking at it from month to month. That gives you a really objective, nice way of looking at the foot and looking at it from month to month straighten itself out, which is what you should notice, especially over the first year. Usually it goes away, doesn't come out, doesn't come back, and you don't have any problems. Child is still walking, doing developmental appropriate things and walking at normal ages when they're supposed to. There is casting that can be done if we want to spur those things along and make it go a little bit faster. There's also different types of prescriptions that we can do for bracing to try to straighten the foot out as well. But usually those are not needed, and it's uncommon that you actually need to do that. So that's sort of the first thing I'm looking at is the foot, and that's in that child who's really young, that 0 to 2 year old, really that 0 to 1 year old child that has a foot that turns in. Also, they haven't really started walking yet, so we don't really know how they're walking until they're sort of getting to that age. And so, as they start to get walking, the foot's usually looking pretty good. It's looking like a normal foot. Otherwise, we probably would have noticed that when they were crawling around. But as they start walking, the feet start to turn in. And this is sort of that second age group that we're looking at, and that's probably the group that's in that 2 to 4 year old range. So they're just getting up and walking. They're sort of toddlering, and they have feet that turn in. And so this second group often goes up a level. And so now it's not at the foot, but it's at the shin level. And that is a term that we call tibial torsion. And all that is basically it's a twisting or turning of the bone once again, this is something that the kids often have, but we didn't really see them walking before, and didn't really notice it. And the shins are actually physically turned in, and the as the body starts to walk and as the body starts to want to go in a straight line, it starts to have all kinds of muscles and stimulating forces to direct it in the way that it wants to go. And so these are things that are often present previously, but as these stimulations happen, the bones actually not only are they growing taller and longer as the child is growing, but they're also unwinding and they're turning out. Because if you think about it, when the child was in the uterus, they were all curled up into a little ball, and so now they're sort of unwinding in these first years, and they're sort of getting their feet underneath them. Just the fact that we're able to walk as human beings is actually pretty amazing, and to get the coordination and the balance and all of those things in place to be able to do it in a reasonable way. The body's pretty amazing in that it makes those adjustments as we're learning how to walk and as we're growing. And so this 2 to 4 year old range, we're usually looking at that. And um, once again, this is something that really observation is primarily what we're doing here. Um, if this tibial torsion or this turning at the level of the shin persists as the kids age, something things can be done, but really there's bracing has not been shown to be effective. Bracing and stretching and exercise and all those things, when you look at clinical data, it really has not been shown to effectively change anything. And so we're much less aggressive about doing braces to try to straighten the feet as we did before. And usually sort of think of traditional sort of boots and bars that are holding your feet apart and pointing them out and those types of things really hasn't been shown to be effective. Really the only way to correct it is surgically, where you're creating a fracture in the bone and you're redirecting it and you're allowing it to heal in that new position. Surgery is extremely uncommon. Needing to go to that extent is extremely uncommon, especially in a typical child who does not have any other associated illnesses or disorders or neurologic deficiencies. It's extremely uncommon to need to do that. So often you'll hear us say as physicians, we're going to watch this, we're going to observe this, we're going to see if the child's going to grow out of this. But that term grow out of it really is the child is physically changing. The profile is there that it's turned in, but the profile is growing its way so that it's straight. And as part of my job when I'm doing an assessment, I'm looking to see that there are not these other things that are associated, like muscle problems and nerve problems and coordination problems and other things that will require sort of a higher level of care that may cause something like that to persist, right? The child should still be meeting his developmental milestones because they're her developmental milestones at normal ages. Tripping and falling is a little bit tricky, right? So usually what we hear is that the kid is tripping over their own feet, right? And in this toddler phase, it's really hard to sort of differentiate, or are they doing that more than their peers? And is it functionally causing a problem? Right? Can they not get to the next level? Are they objectively behind on some milestones that we would need to do an assessment, get them into some exercise and therapy so that they can catch up? Once again, it's also pretty uncommon that it's to that extent. It's usually that the kids are sort of figuring out how to keep their feet under them. And as they gain coordination, as they gain balance, as they gain muscle strength, these things sort of improve on their own. And children really do learn through play and they learn through just discovery. And they're doing their own therapy on a daily basis by just exploring the world. So we've now hit that age group of 2 to 4. So they've sort of gone through to being a baby and they sort of turn in, but now you're sort of hitting an older child who's still turning in. And this child usually is between 4 and 6. They're turning in, but you're noticing that their knees are turning in, or when they're running, their legs are kicking out to the side. And often this is turning in at the foot level due to the hips. And this is called femoral aneurysm. Fancy term, once again, just basically meaning that the hips turn in more than they turn out. And now instead of the twisting being at the shin level, it's at the thigh and the hip level. And so these kids tend to like to W sit. They can sort of turn their knees to face each other. And when they walk, sometimes you'll see their knees facing each other as they walk. and the feet are just a manifestation of what's going on further up the chain. And you just see the feet on the ground, but really the turning in is happening at the hips. And this is something that also the hips are also developing, usually to about age 9 or so. They're constantly changing. Once again, this is something that is persisting from childhood. In infancy, we have this aversion, which is typical, and as we're maturing, that aversion or that twisting is constantly um, writing itself to its adult position. And anywhere between 9 and 11 years of age, it tends to sort of max out. And to some extent, some studies have even seen in teenagers where it will change a little bit more to that final adult position. But really, once again, it rarely causes any significant problem. But now you have, of course, an older child who may be a little bit clumsy, who still may be turning in, who may be running awkwardly, right? And so, but the indications here, once again, bracing really has not been shown to be effective. So we're either talking observation, which is going to be the vast majority of patients, or we're talking about a surgical intervention where, once again, you're creating a fracture, redirecting the bone, and then allowing it to heal in that new position. Really, the only indications for doing something there is if it's causing a significant functional or cosmetic deformity, it's causing psychological stress, if it's causing pain. So the kids are having actual physical problems walking, and it's causing some type of distress where we're really trying to change the forces around the hip and around the legs to help. And so all of these different conditions, it's pretty uncommon to need to go to surgery, and that's what I really reinforce is this education component. Um, there is also a component of muscular training as well, right? So as we're aging, there's this immaturity that we haven't necessarily gained full coordination yet, and so sometimes it is also beneficial to have an assessment to see, okay, so we can turn our legs straight if we're thinking about it, right? We usually can point things in the right direction if we're thinking about it. When we go into that subconscious state and we're not thinking about it, our legs will naturally drift in. Well, we can also focus on awareness, body awareness, strength. So working on some of those hip muscles and make sure they're strong, and those external rotators and those muscles that will turn you out and keep you out, as well as coordination as well. So there's some other things that can be done, but of course you can imagine, trying to do therapy with, a 3-year-old is fairly challenging. And so if we're having some of these things that are persistent to these older ages, these are some other things that we can try. Once again, the clinical studies have not necessarily borne out that physical therapy really is a durable option, but it does work for some patients. It is helpful, particularly in those who are tripping and having some coordination issues. So, as a physician, when we're looking at things, we're really looking to make sure there's not some of these other things that are going on that can create a problem that need to be addressed later. But all in all, when we're looking at bracing and doing things early, there's not really much to do early for the majority of patients who are otherwise healthy. Now, we are diligent about watching and we're diligent about observing and making sure that there's not a functional problem. And while there's not, we do let the child develop naturally and develop typically. So, if you have a concern, obviously give us a call, let us know. We're happy to evaluate, and then also happy to talk out exactly what's going on, at what level we see the issue, and also the expectation of when we expect that to correct itself, and what are the warning signs, right? What are the things to watch out for? And I think we discussed those are primarily those functional problems that are keeping a child from doing what they would typically do at that certain age. So if you have any questions, definitely please feel free to leave them in the comments. We would love to respond to them. We love to hear your feedback, as well as I know that there are some other special situations that people want to discuss as well, and we're happy to talk about that offline. Anyway, have a good week, and we'll see you the next time. Bye.